podcast practice. Hello, everyone. We'll get started in just a few seconds as people gather around and join us. I'm watching the participant button popping like Jiffy Pop popcorn, and when it slows down, then I'll start. All right, hello everybody and welcome. I am Dr. Jeff Katzman, the Director of Education at Silver Hill Hospital. We are absolutely delighted to have you join us for our virtual grand rounds today with Dr. Robert Feinstein, presenting on the topic, the Big Six Treatments for Personality Disorder, Commonalities and Differences, and I will introduce him in a moment. First, some housekeeping notes. Toward the end of the lecture, I will moderate a question and answer discussion, and these questions are an important component of our grand rounds, and as always, we really value hearing your questions and comments. The Q&A link can be found at the bottom of your screen. You can submit a question anytime during the lecture, either with your name, or if you prefer, you can submit it anonymously. Another important component of the lecture is offering CME and CEC credits to our participants. To receive a certificate, please complete the evaluation survey that automatically pops up in the browser when the webinar ends. We will also email a copy to all participants. Finally, disclosures. All of the planners, speakers, or individuals in control of content for this educational activity have no relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on or with patients. It is now my great pleasure to introduce our guest speaker today, Dr. Robert Feinstein. Dr. Feinstein is currently a psychiatrist and psychoanalyst in private practice, providing patient care and organizational consulting in his office in Stamford, Connecticut. He's a clinical professor of psychiatry at the Donald and Barbara Zucker Medical School at Northwell, Hofstra. He teaches and supervises at Zucker Hillside Hospital in Long Island, New York, and from his private practice. Dr. Feinstein was an undergraduate at Michigan, then studied medicine at New York University School of Medicine, and was a psychiatry resident at Albert Einstein College of Medicine in the Bronx. He trained as a psychoanalyst at Columbia University Center for Psychoanalytic Training and Research. Dr. Feinstein was formerly professor of psychiatry at University of Colorado School of Medicine and Dell Medical School. In addition, he served as Senior Associate Dean of Education at the Colorado School of Medicine and is a University of Colorado Denver President's Teacher Scholar and former Director of Psychiatry Residency Training at New York Medical College. As a clinician and administrator, he was Director of Psychiatric Emergency Service at Jacobi Hospital in the Bronx, New York, and was Associate Director of the Borderline Personality Disorders Unit at NYS Psychiatric Institute and Columbia University College of Physicians and Surgeons. He was also a developer consultant to 5 state crisis intervention services in Connecticut. He was Vice Chair of Education at the University of Colorado Medical School and Associate Chair of Education at Dell Medical School. He was also the Director of the Outpatient Clinics at the University of Colorado. Rob has written over 100 publications in the primary areas of psychiatric education, psychotherapy, personality disorders, suicide and violence prevention, behavioral change, health and well-being, and integrated care. He has also authored 3 books. In 2017, he edited a book entitled Integrating Behavioral Health and Primary Care, published by Oxford University Press. I met Rob years ago through our mutual colleague, Dr. Joel Yeager, when Rob was working in Colorado. And Rob and I recently shared a cup of coffee after both of our moves back east, and he let me know of his latest book, the primer on personality disorders, written this past month by Oxford Press. This is the most current and comprehensive description of diagnoses and evidence-based treatments of personality disorders to date, with contributions from the major leaders in the field. Here it is. I just got my coffee, and it's, I will say it is brilliant, and also Anne has purchased a copy that's now sitting in our library. So after we had coffee, I I asked Dr. Feinstein if he would please consider joining us at Grand Rounds at Silver Hill, particularly now that he has moved to our area, to New Canaan, and hopefully will join us in supervisory and increasing teaching efforts. So thank you, Dr. Feinstein, for your talk and on the big 6 treatments of personality disorders. It's an honor to get to see you, to introduce you, and to learn from you once more. I now hand the baton to you.
Great. Well, thank you very much. It's a pleasure to be here back in Connecticut. I really enjoy that. I understand there may be some friends who work with me at New York Medical College. For those of you who are out there, hello, I can't see you, but maybe we'll get together at some point when I'm up at Silver Hill. So pleasure to be back in Connecticut. So I'm going to, I have nothing to disclose except for what Jeff already mentioned, that I wrote this book with Oxford University Press. And this talk is based on both my writings in this book. I wrote 3 chapters in this book, and then resources that came from the other 54 authors who contributed to the book. So the talk today is a bit of a mission impossible. And the reason I say that is because I'm going to cover the 6 evidence-based treatments, evidence-based psychotherapies for the treatment of personality disorders. So this is a lot of information. And it's not so much that you understand at the end of this talk how each of these 6 forms of psychotherapy actually work, but as I describe them, listen for the commonalities. What do they do differently and what do they do in common? Because I think they do way more in common than they do different. And that becomes very valuable to clinicians. And so the second part of my talk will be to gather all of the things that they do in common and give those things to you in a way that you could use these things in the treatment of personality disorders. So the objectives quickly, I'm going to just give you some information about the prevalence of the personality disorders and some of the clinical implications. I'm going to describe the evidence for these big 6, I call them the big 6 evidence-based psychotherapies. And then I'm going to give you an overview of each of these forms of treatment. And then probably the most important part of the talk comes at the end, where I discuss 9 commonalities that all of these treatments have that you can use in your practice to better treat patients who have personality disorders. So personality disorders are everywhere. Their prevalence is very highly setting dependent. So the average number of personality disorders in a community sample runs around 12%. You can see the range. And the interesting thing about that is, taken as a collective, personality disorders as a collective, as a group, all of them are the most common disorders in the DSM-5. And we don't tend to think about that because we think about the individual personality disorders. And the most common ones are OCPD, about 8% of the population, narcissistic personality disorder, around 6%, and mixed personality disorders. We think that's very, very common. There's no data on that because there's not really a good definition of what a mixed PD is. But if you change the setting a little bit, so in a typical outpatient mental health setting, these are clinic settings, it varies depending on where you are in the country, but anywhere from 8 to 20% of patients, and the most common diagnoses in those settings are narcissistic and borderline personality disorders. Everyone knows if you work in the ER, a lot of your time is going to be spent with borderlines who are coming in with suicidal gestures or suicide attempts. And so that's the highest diagnosis in an emergency room setting. Now, if you move to substance use or forensic, the numbers go up even higher. So about 30% of patients in a substance inpatient treatment unit have some personality disorder, and 50% of forensic, where the most common disorder is the antisocial personality disorder. Now, not surprising to those of you who work in a consultation liaison environment, the neurologic conditions are highly comorbid with psychiatric disorders. So 32% of patients who have migraines meet criterion for at least one PD. Patients who have non-epileptic seizures, around 40%, and somatoform pain disorder. And for the neurologic group, most of the PDs in those groups are cluster B patients. antisocial, borderline, histrionic, and narcissistic. Now, this is really interesting, and I think people don't understand sometimes the importance of this. So it turns out that the prevalence rate of personality disorders with DSM-5 classified disorders is very high. So if you look at unipolar depression, 50% of patients with the unipolar depression have one comorbid personality disorder. When you look at treatment refractory depression, and this is a really interesting group, it's about 25%. So sometimes this means that people are getting ECT with the belief that they have treatment refractory disorder, when in fact, they more typically have personality disorders. And that raises the question as to whether ECT is indicated for them or not. And this group tends to be patients who have over-controlled personality features, such as paranoid personality, obsessive compulsive personality, or avoidant personality. Now, everyone knows the overlap between bipolar disorder and comorbidity. The most common one there is borderlines. So about 25% of patients who have bipolar have borderline. And that's a tough differential diagnosis because the symptoms overlap, but a very important one to make. And trauma and PD is really common. About 35% of patients who have post-traumatic stress disorder have a comorbid personality disorder. You can see these numbers for panic and agoraphobia, about 47%, social phobia, about 48%, and OCD, that should have read, that's a typo, have a comorbid diagnosis, and about 30% of those for the OCD have OCPD, the OCPD personality disorder. Now, the implications of these are quite striking, and this is really what led to my developing this talk. So the first thing to think about is if you're treating any DSM classified disorder and you're not attending to the comorbid personality disorder, whatever it is, your outcomes are going to be worse. And that's a problem. So a lot of times we don't do well with depressive patients, and it's not simply because we've not chosen the right meds. Oftentimes it's because we're not in a comorbid way simultaneously treating the personality disorder. Now, the other important fact is that if you treat the DSM disorder, which might be depression or bipolar or panic attack, those treatments will be very effective, but they have no impact at all on the treatment of the personality disorders. They don't make them better or worse. They do nothing to them. So you might get the DSM disorder, but you won't hit the personality disorder, and the presence of the personality disorder will make that other DSM disorder more likely to recur. The other issue here is that medications in the treatment for personality disorders are basically completely ineffective. There's no meds that we can use to treat a personality disorder. That doesn't mean that we aren't prescribing a lot of meds with patients who have PDs, but they're not primary treatment. And usually if we are using them, we should be using them to target their other disorder, not their personality disorder. So you should be considering medications as at best adjunctive in relation to treating them with another comorbid DSM-5 diagnosis. So now that leaves us with this fact, which is partially the basis for this talk, which is that the only effective treatments that we have for personality disorders are psychotherapies. And there are many of them. I'm going to talk about the 6 that have the big 6, I call it, that have the most data and the most effective treatments we have for the PDs. And they're all approximately efficacious at about 70%. That's as good as any medications we have. That's as good as you're going to get for an antidepressant. In fact, if you just look at the NNTs for an antidepressant, you'll see them around 12 to 14. But the actual remit rate when you put back placebo for depression and medications runs around 60%. So we're equally effective as treating a personality disorder as we are treating a major depressive disorder. And a lot of people don't feel that way or don't know that. So here's the dilemma for many clinicians. We understand the need for the treatment of the personality disorders, but many of us feel we don't have the skills to do it. If we don't like these patients, we don't have the inclination. It takes more time to treat these patients. And sometimes you don't have a choice because you don't have any place to refer them to people, or you can't get access to the specialized treatments that these patients may need. Now, there are common treatment approaches, which I'm going to review with you today from the big six, evidence-based psychotherapy. And I do think there are aspects of all of these treatments that can be used by a general psychiatrist or a therapist for the treatment of PD without your having to get the specialized treatments that we know work for patients who have personality disorders. That's my core thesis for today. So now I'm going to take you through these things in a lot more detail. So first, I'm going to describe what these big six are and how they work, some of the differences and commonalities. And then I'm going to describe a general psychotherapeutic approach you can use based on these PDs to treat many patients with PDs. So you probably recognize this group. This is the famous group of psychiatrists that have brought us the evidence-based treatments for all the PDs. I'll talk more about them in a moment. And if you're interested and get the slide deck, these are the manuals that go with them, which are very interesting manuals to read if you want to learn more about the details of how to use these specific forms of treatment while you're treating your patients. So here's a little history about these big six. So the history started in 1975 by Otto Kernberg in his famous book, Borderline Conditions in Pathologic Narcissists. He is and was a psychoanalyst, and he was the first one who said sort of open-ended, free-flowing psychotherapy doesn't work for these patients. The treatments need to be much, much, much more structured. And he was the first one to sort of lay out what this group of disorders look like, but also the first one to say, we can't do traditional open-ended psychotherapy with them, it doesn't work. So that form of therapy began in 1975 and has morphed with his help and Frank Yeomans and Clarkin and Eve Callagore to the current rendition of that, which is called Transference Focused psychotherapy. But around the same time that Kernberg was doing this, Aaron Beck joined the picture in 1976, and he tried to use cognitive behavioral therapy. What happened with him was interesting, was that cognitive behavioral therapy for personality disorders, as you know it, didn't work very well. And it didn't work very well primarily because they weren't focused on the relationship with the patient. They were focused on skill development. And when you work with personality disordered patients, working on the relationship becomes imperative. So they were not very effective at all in treating patients with PD, although they wrote a lot of good literature that was picked up by others and then transformed and used. More recently, they developed a specialized treatment called MAC, which is a specialized CBT form of treatment for personality disorders, which seems to be developed. They have much less information, but seems to be becoming effective as they use the modifications. Now, alongside of that came dialectical behavioral therapy. An interesting story about this was many years ago, Otto Kernberg and Marshall Linehan were both at the Westchester, Cornell Westchester in White Plains. And I went to a conference back then, which was really fun. Kernberg was presenting, so was Marsha, and they were each presenting a tape of the same patient they saw. This was a live patient. And Marsha went up and she did her interview, and we watched the interview for 45 minutes. And then Otto Kernberg came up and we watched his videotape for 45 minutes. And at the end of that time, each of them spent about 15 minutes talking about their theory, what they did, what worked and what didn't work. But the most interesting part about that is then it got to the audience for an open discussion. And the audience's reaction was very different. They kept saying that the differences were much less important than what they had in common. And they were reporting out specific examples where Dr. Kernberg was using behavioral interventions that were supposedly limited to Marsha Linehan's treatment, and the reverse. When people were critiquing Marsha's treatment, they said, she's making an interpretation. Here's a clarification and a confrontation. And I think we've come to the point of saying, and this is sort of where I am, that master clinicians are doing way more in common than they're doing in different. And yet our tendency is to emphasize the differences and start these psychotherapy wars, acting like one therapy is significantly better than another when the data does not show that to be true. In 1999, Fonagy and Bateman came along and they developed mentalization-based treatment. This is a very effective treatment for borderlines, and we'll talk more about that. And their set was to use a partial hospitalization program using this form of therapy with patients who have borderline in England. They have really good data about its effectiveness, also around 70%. And not to be undone, Jeffrey Young came along, and he developed Schema Therapy. Now, Schema Therapy is one of these eclectic therapies that borrows heavily from cognitive behavioral therapy, but also borrows from experiential therapy and has a lot of psychoanalytic principles integrated into it. So this is sort of an amalgam of what's been learned from the other forms of treatment built into one new treatment, and I'll tell you a little bit about that. Most recently, John Gunderson was the original developer of good psychiatric management, and this has really taken off because this is a form of evidence-based management of patients with borderline that's quite effective, and the training to learn how to do it takes about a day, where the trainings of these others can take a year, 2 years. If you want to really learn how to do them, they're much more intensive to learn how to do those treatments. So these are the big six. Now, what they all have in common is that they all have a similar belief about the origins of personality disorder. And that is that personality disorders have a certain genetics that move them in this direction, and they all have early life trauma, a little bit about each. So it turns out that if you look at all the DSM diagnoses, all of them are modestly to moderately heritable. Heritability rates run around 0.5 to 0.75 heritability. And it turns out the three most common traits that are being inherited are negative emotionality, high impulsivity, and low agreeableness. And also some data that introversion. So when we think about the origins, the genetic origins that input into personality disorders are usually tracking in one of these four areas of traits. But that's only half the story. The other half the story is about early life trauma. So we know a lot about trauma and the PDs, and there's no longer a debate about how important trauma is as a significantly contributing factor to, basically to all the PDs, but there's some differences. So here's some general data. So childhood abuse, if you've experienced it, you are 4 times more likely to have a personality disorder than someone who has not been abused. I find that very striking as an important part of the etiology. We know that verbal abuse in childhood increases the likelihood of having dysfunctional personality traits. We don't get a disorder associated with that one. Physical abuse, though, is correlated with an increase in the development of antisocial and depressive personality disorders. Sexual and emotional abuse is more correlated with the borderline personality disorders. When I worked on the borderline personality disorder unit at Columbia, literally 50% of the women on that unit, I worked on that unit for 3 years, 50% of the women on that unit had incest with a brother, a father, an uncle, some close family member. Very, very prevalent. And neglect, so the so-called invalidating environments, those are associated with many of the PDs, including the avoidant, borderline, narcissistic, and passive-aggressive PDs, antisocial as well. So when you think about the commonalities, PDs are caused by genetics, which we understand to some degree, trauma as the major causes. And all 6 of the evidence-based treatments agree upon this. Another way to think about them, again, in commonalities, is to think about them as though they're a neurodevelopmental disorder. So just as a prototype, to give you an example, if you think about how we work with patients who have ADHD, what we tell them is that they have certain brain processes disorders that affect their ability to focus and stay concentrated and not be distracted. And then we also add that part of that deficit comes from a developmental experience and learned behaviors. Well, there's a case being made that all of the personality disorders could also be conceptualized as neurodevelopmental because they have very similar brain deficits. What are these deficits? They have a deficit, a real inability to know themselves well and know others. They have difficulty predicting and understanding their own and others' behaviors. Many of the patients of the severe kind, and you see this in patients who've had transient psychotic episodes, have problems distinguishing their internal experience from their external reality. You can see this in some borderlines. All of them struggle to reconcile conflicting thoughts, feelings, and mental state, and often just wind up in a state of confusion. And many of the patients who have personality disorders have deficits in the dysregulation of emotions or hypersensitivity. And almost all of them have behaviors that interfere with relationships, disrupt their ability to love, to work, and to play. So I'm not going to spend a lot of time on this, but just a little data to take you very quickly through the fact that these disorders have been really well researched. So if you look at Transference Focus, they have 3 good meta-analyses, 3 RTCs that have demonstrated that that form of treatment can decrease the symptoms of a borderline, including decrease suicidality and parasuicidality. Mentalization-based treatment has 3 meta-analysis and 3 systematic reviews and 6 randomized controlled trials. And their data shows that their treatment can reduce the severity of the symptoms of whatever personality disorder the patient may have. It often may help treat a comorbid disorder, and it improves the quality of life and clinical outcomes. DBT is the one that's most studied, so people act like this is the only effective treatment, which it is not, but it's a very effective treatment. They have 7 meta-analysis, 2 systematic reviews, 15 randomized controlled trials, and their data indicates that they can get the diagnosis to remit, typically if the treatment goes longer, usually 1 to 2 years, that for borderlines, they can get a decrease in symptoms, decrease in self-harm, suicide, depression, and anxiety. Now, Schema Therapy doesn't have quite as much evidence, but it has a very good systematic review, 3 randomized controlled trials, and they show that there's a decrease in borderline symptoms, and they show an improvement in a change in their early life cognitive maladaptive schemas. Now, good psychiatric management, originally they were using this as a control in the treatment, in a comparison treatment with DBT. So they were comparing DBT to good psychiatric management. And they were really surprised to find out that good psychiatric management did as well as DBT. This was an unexpected finding, and a very important one, because it takes a lot less time to learn how to do good psychiatric management than it does to learn how to do DBT. Now, CBT, as I mentioned to you, has the most mixed capabilities. They have 8 randomized controlled trials, and some of the evidence indicates it works, some of it doesn't. CBT's difficulty really has to do with the fact they don't focus enough on the relationship with the patient. And when you have a patient who has PD, that becomes essential. So what they've done is they've morphed that treatment now, and they call it manual assisted cognitive therapy. They've taken out the B, so I'll refer to that sometimes as CT. And they've got some pretty good trials showing that. And what they've added are specific ways to develop an alliance with a patient, and that's improving their outcomes. And I think over time, they'll be every bit as good as the other forms of evidence-based psychotherapy. So here's the joke. It says here, use any of the big 6 treatments, and 6 out of 6 pickies will take you to market. What does that mean? It really means the dodo bird effect, and it applies to all 6. Everybody's won and all should have prizes. What it says is all of the treatments that I mentioned are effective in the treatment of patients who have borderline personality disorder, and they're all effective at about 70% rate. Now, the implications of that we'll be talking about, if they're all effective and they have so many different theories, well, maybe it's not the specific theory that's responsible for the outcome, but maybe it's about things that they have in common that are responsible for the outcome. And that's the thesis I will be presenting to you today. So I want to take you through briefly to orient you a little bit to the different forms of psychotherapy. There's a lot of material here. Don't worry if you don't understand it, but it's important for you to know that there are these different forms of treatment, so that when you're stuck with a patient doing DBT and the patient is not getting better, it's important to recognize you have 5 other choices of treatment that you could recommend to a patient. And that now is the trend. If you can't get a patient better with one form of treatment, then switch to another. So here's a brief review. So Transference Focus, as I mentioned, was developed originally by Kernberg and is now being done by Kernberg, but also led by Frank Yeomans and Clarkin and Eve Calgore. It's a psychodynamic theory based on ego psychology and object relations. They've added components to it focused on attachment theory. And the core idea is that the building blocks of the mind are self and other object representations and the affects that connect them. And these represent interactions with people in our lives. They also believe, as do all the others, that constitutional factors and early life traumatic or adverse experiences are responsible for the development of the PD. But the goal of their treatment is to understand these self-representations and these object representations that are often split and try to get them integrated. And the point of that is when they're not integrated, people have very unstable relationships and very unstable identities. So what Transference Focus tries to do is to get these object relations integrated. And if you can do that, it will reduce impulsivity. It permits healthy development of dependency and allows a better capacity for intimate relationships and good interpersonal relationships, and also helps shore up the moral structure of patients. As a psychoanalyst, you might say that these object relations are the building blocks of the ego, the superego, and the ego ideal. Now, they use a very specific treatment frame, and I'll talk more about that. The treatment frame are sort of the rules of therapy and the structure that stops the therapies from blowing apart from people who live volatile and sometimes chaotic lives. Now, they have a very different, and you'll hear about this, each of these therapies has a different attitude towards the relationship that they should have with patients. Transference Focused takes the idea that the therapist is there not so much as a warm and caring person. That may happen, but that's not the point. From their point of view, you take the role as an expert, and what you're there to do is to provide a holding environment for the patient in which their emotional storms and difficulties can be contained long enough so that the psychological work can proceed. Now, this group of treaters feel that the transferences and countertransferences are really important, and they pay particular attention to something called the global countertransference as important information. And I'll talk a little bit more about that in a little bit. Now, the next treatment to come along was mentalization-based treatment. This is a psychoanalytic cousin Transference Focused. So they are psychoanalytic in its origin. They're a bit more focused on attachment theory, and they're really tracking the neurosciences of how we come to develop a sense of ourselves and how we become to develop the capacity to read the intentions and beliefs of others. They, like the TFP folks, also believe that genetics and early life adversity leads to, in their case, they emphasize that those things lead to an insecure attachment. And when you're insecurely attached, that's when they believe your capacity to mentalize somebody gets distorted. So without a good attachment, you have difficulty understanding how you feel, and you have difficulty about reading the intentions of others. So if you follow their theory, the goal of their theory is to do everything and anything you can do to increase their capacity to mentalize themselves and to mentalize others, saying that it's deficits in both of those areas that create problems of self-esteem and identity on the one hand, and problems in intimate and interpersonal relations on the other. They take a very different alliance relationship to their patients. They take what's called a not knowing stance. And so they don't take that expert position. They don't do deep interpretations the way the Transference Focused do. Rather, they assume that the patients know their minds well enough, and that the patients have to describe for us how they mentalize, and describe for us how they mentalize with others. And we have to learn about that from them. We don't know this information a priori, and that we also have to practice in the treatment, them mentalizing us and us mentalizing them, and find out where those distortions are and work about improving them by an interaction, a conversation that goes on between therapist and patient. So what they have learned from attachment theory is that some patients who have personality disorders, they attach too easily. They glom on very quickly. So this would be the dependent personality, some borderlines. They attach too easily and too intensely. They've also learned the opposite, that others in this group don't attach enough, the paranoid personality, the antisocial personality. And so their interventions are to move back and forth to facilitate. If they attach too intensely, then they move distant from the patient so that that's better regulated. If they don't attach enough, they move much more closely and much more intimately to help the patient attach. So a lot of their interventions are the back and forth, understanding their capacities to mentalize. That's a little bit about mentalization-based treatment. Now, the joke that people have in this is, when you're talking about it, is, of course, I care about how you imagine I thought you perceived I wanted you to feel. It's a meta position. You're always in a meta position, wondering how you feel, how the patient feels, how you imagine they feel, how could they feel different in a different situation. This kind of reflects an experience when you work in this framework. Now, I suspect most of you are very familiar with DBT, as I hear that this is a very large program you have in your outpatient setting, so this won't be news to many of you. But for those who are not that familiar, DBT is a third wave treatment that came from CBT, but actually I would argue has stole a whole bunch of things from Transference Focused. It's the Linehan-Kernberg story. And their basic theory, it's a biosocial theory, and they think that the deficits in borderlines come from biologic abnormalities. They say there is a genetic component, but it also comes from early life experiences of trauma, but maybe more softer kinds of invalidating environments. So if you think about a patient who has narcissistic personality disorder, parents who have that, and imagine how they might treat their kids, you'd have a sense of what an invalidating environment might look like. And their core principles are to think about, and I find these very valuable across all theories, to think about the work with these patients as a dialectic, And the dialectic that they're talking about is that opposites can coexist. And when you work with patients, it means first that you have to help them accept who they are, and you have to accept who they are as a therapist. And you do that through empathy and validation. And once a patient feels that they are accepted and validated, then you can start part 2 on that, which is ask them to change. But they're very specific, and I agree with them that the validation and acceptance has to come first before there are any requests that they make any changes. Now, the alliance from a DBT clinician is a bit different. So they view themselves as coach, and they're non-judgmental coach. So if you call up a DBT person and they're suicidal on the phone, someone from DBT will coach that patient how to use DBT skills to get control over their suicidal impulses. So they see themselves as sort of non-judgmental coaching, teaching their clients how to use the behavioral skills that they use. And another thing that they're very firm about, this originally came from CBT, but I think was implemented better from DBT, is they're very careful at looking at behaviors that patients have that interfere with the treatment. They call these treatment interfering behaviors, such things as being suicidal, such things as substance abuse, any things that are conscious or unconscious that interfere with treatment, they call treatment interfering behaviors. And they focus on those by using intense limit setting. And the purpose for that is to get the patient stable, stop them from doing destructive behaviors, and get them to be practicing the behavioral skills that create change. And the 4 skills of DBT, most of you are well aware, are teaching about acceptance skills, which are mostly teaching about mindfulness and distress tolerance, or teaching about the change skills, which are focused on emotional regulation and teaching interpersonal effectiveness. Now, CBT has added an awful lot theoretically, but lagged behind in terms of their ability to deliver their treatment for the reasons that I mentioned. They have a similar idea that genetics and early life experiences are responsible for the development of PDs. They're very focused on the core problems that patients come in, the current situation, and they are sticking to their idea about looking at the automatic thoughts, emotions, and behaviors. And they were the first ones to introduce this idea that each of the personality disorders are associated with a core belief or a schema. So just one example, the core belief of a paranoid patient, according to CBT, is that people are out to hurt me. Now, if you have that core belief, then you're very fearful that you're going to be hurt. And we could go through, and CBT does this, each one of the personality disorders and says, what's the core belief that is associated with each personality style? And this has been very effective and picked up by Schema Therapy and used in a really effective way. Now, the goal of CBT is to get at these core beliefs and the maladaptive coping that comes from them, and help a patient develop the emotional control, self-sufficiency, and adaptive interpersonal relationships. But they're focused much more on the behaviors, somewhat on the thoughts, and not particularly that much on the emotions. Now, their view of the alliance is what created some problems for them when they were treating personality disorders, because they see the alliance as much more an alliance of collaborative empiricism, meaning that when you work with a patient, you weigh the evidence. What's the evidence for this? What's the evidence for that? And they also emphasize that what makes you better is acquisition of skills, not a relationship. It's if you can get the skills, you'll get better. And actually, for treating depression and anxiety, that turns out to be true. If you just emphasize the skills, those patients will get better, and the relationship may not matter that much for depression and anxiety. It matters a whole lot when you're working with personality disorders. And these guys also developed some of the idea of working on the treatment interfering behaviors and setting limits as a way to stop these patients from acting out. And they're pretty structured the way they are. And they set specific goals for each session, which is much harder to do when you have a personality disordered patient. They use cognitive restructuring and a lot of the cognitive tools that track with traditional CBT. Now, schema therapy, that's Jeffrey Young. He's interesting because what he did was form an eclectic theory. So he borrowed from everybody, but also has the same belief about genetics and early life experiences and the etiology of all the PDs. But his concepts are a little bit different. He says that patients have 5 universal emotions that they have to work through. And they are the ability to have attachments, to develop autonomy, competence and identity, to have the freedom to express valid needs and emotions, to be able to be spontaneous and play, and to be able to have realistic limits and set self-control. And the goal of schema therapy is to help patients get effectively to meet any one of these universal emotional needs. Now, they do this in a way that's a little bit different, which is they view the alliance much more like a parental relationship. As a therapist, you're a good father, you're a good mother, you're a good brother or sister. And they call it limited reparenting because they take on a parental attitude, but they don't act like full parents. And their goal is to help you identify the core beliefs that you have and that you carry with you, and identify these core beliefs, modify them in your coping style, and move your functioning from the pathologic modes, which they define on this slide as a child mode. So some people will act as an angry child, a vulnerable child, or acting in a dysfunctional parent mode where they're acting very punitive or demanding, or they have a dysfunctional coping mode. And the goal is to work within these different modes. That's a handful to say, and they have very specific ways to do that to help develop a healthy adult. That's a complex treatment. But in addition to using CBT things, they're also a very experiential treatment. So they borrow from Gestalt and psychodrama as they do some of these interventions. Now, last but not least is good psychiatric management. This was originally developed by Gunderson and is now being taught a one-day seminar. A great one-day seminar, if you want one, is at McLean's. They're also of the belief that genetics and early life adverse experiences are the basis of PDs. Their goal, though, is a little bit different. They say the goal that when I'm going to work with you, the goal is for you to create a meaningful life. And they define a meaningful life as work, as good interpersonal relationships, and as liking yourself. And the way they do this is they do traditional outpatient psychiatric management with their patient, meaning they see them in supportive psychotherapy and meds. But most of the interventions they use are using outside resources. So if you're in good psychiatric management, you're also probably going to AA, Alcoholics Anonymous, if that's an issue. You might be in a partial hospital program for borderlines. You might be in an IOP. You might have a case manager. So their idea is, let's have a core therapist, but let's provide for you external resources that will help you get your life together so that you can have meaningful work. So they may give you an occupational counselor, a family counselor. It's a multimodal treatment where you decide what are the external resources that need to occur that impact with the single person who's managing all of these things and setting them up. And interestingly, this works really well in many general psychiatric settings with about the same good outcome as any of the other treatments. So that's a mouthful. Hope it wasn't too much. I'm going to now distill this for you in a way that maybe will make it useful for you when you think about your efforts to work with patients who have personality disorders. And I will say that because of the 70% efficacy, it is my belief that it's the things that these therapies are doing in common that are mostly responsible for the good outcomes. And I'm going to run you through each of the 9. So the first is accept the patient's emotional state. We'll talk about structuring a treatment, how to use your own self-awareness and foster awareness in a patient. What is the therapeutic alliance and stance that works best? How will you manage the counter-therapeutic interventions that you may find yourself in, or counter-transference reactions? How to become more responsive to the patient's needs? What do you do when you have working alliance problems? And how do you manage resistance repairing and the therapeutic alliance? I'll also spend a little time talking about consultation and supervision. We're going to take these one at a time. So this comes really, I think, best expressed through DBT. This idea that we talked about, that patients have to accept themselves, the kind of emotional people they are, and the emotional experiences that they have as sort of the first step in treatment. And we know that when we're working with personality disorders across the spectrum, we sort of have 2 types of emotional states that are useful to think about. We have the states of the borderlines, and that's, we know this better. These are the patients who are hypersensitive to emotion, who are hypersensitive to rejection. They get overwhelmed easily. They can be very angry or very tearful or very dramatic. And they have a certain, if they get emotional, they dysregulate very easy. And this group of patients tend to be the patients that have borderline or histrionic or narcissistic or avoidant PD, the group that's very hypersensitive to emotions. And I sometimes, when I work with a schizotypal patient, I think that group also is very, very heightened sensitivity to emotions and feelings, even though they don't express it. They're hurt by them very easily. On the other side of the spectrum, though, which we don't tend to think about, are those patients who have a much more rigid or controlled style of emotions. So when you have a PD, you can be too much emotions, or your emotions can be too rigid or controlled, right? And we see patients have over-controlled emotions. That's the group that maybe is antisocial personality disorder, paranoid personality disorder, very controlled in their emotions. And certainly OCPD patients, obsessive compulsive personality disordered patients, who basically when you work with them, they'll tell you all the things that go on, but you'll have very little idea about how they feel about things because they're very controlling of their emotions. So when you work with patients who have that, figure out which side the patients are on. Are they over-controlled? Are they under-controlled? And help the patient accept them. And you have to accept that that's how they are before you can before you can move on to start to think about how you might help them and how they might change. So the next part about this is because they're such difficult patients and because they have severe behavioral disturbances, it turns out that structuring a treatment with any patient who has a PD is really important. And these, the structuring of the treatment was really developed in its initial conception by Kernberg, but then was adopted basically by all of the 6. They structure the treatments in somewhat different ways, but the need for a structured treatment is ubiquitous. So what do we mean by that? It means that you have to create a safe and consistent space where the work of psychotherapy can proceed in an uninterrupted way. Almost all of these treatments require two time a week sessions, with the mean duration for effectiveness being about a year to 18 months. So about a year to 18 months at 2 times a week is the typical structure that all of these treatments need to get to the 70% efficacy. And part of structuring the treatment is developing a contract with your patient. And how do you do that? Well, it's really important that you go over very specifically to a patient, what are your roles in the treatment? How can you make this treatment good for you? And also that you then specify what your roles are as the therapist. What are you going to do to make this person better? So spend some time specifying the patient's roles. So I might say something to a patient when I do transference focused. I may say something to a patient like this. When you come to treatment, what I want you to do is bring in any problems you're having in thinking, in feeling, in your behaviors, or interpersonal relationships. That should be the focus of our treatment. I want to hear about all of those problems. And then I'll add another piece. If those problems are not available to you, then say whatever comes to your mind. Classic analytic way to structure a treatment, as one example. There are other ways to structure treatments as well. It's also important that when you set the treatment, whatever mode you're using, that you have specific goals. What are you working on? Are you working on having better interpersonal relationships? Are you working on getting a job? Are you working on getting married? Are you working on being a better parent? Are you working on falling in love? What are you working on? What are the goals? And you want to lay those out very specifically, and then you want to lay out how you're going to try to address them within the context of the treatment. It's also important that the treatments can be organized around helping patients make their life choices. And that may be you structure the treatment around what kind of work do you want to do? Do you want to go back to school? Do you have plans to be married? Do you have spiritual needs that are not being met? What are the life choices that you have? And can we work to help you accomplish those? Again, structuring that. And that you have to set up with each individual patient. It won't be news to anyone listening to this that you have to set the boundaries of treatment. And that boundaries of treatment have to do with how often you're going to meet, how long the sessions last, how payment works, discuss how you're going to handle medications, confidentiality, contact with others, et cetera, et cetera. Setting the boundaries of the treatment become really important with all these patients because of their tendency to push us as clinicians to act out and to cross boundaries. All of the treatments will prioritize as first and foremost working on suicide and homicidal threats. So no matter what one of these evidence-based treatments you're doing, if these things emerge, either of those, that's all you do until they're resolved. If they're suicidal, you just stay on that until that's resolved and you've worked it through. If they're homicidal, you stay on that. You don't change topics. And if those things emerge, they're the number one priority. Everything else can wait. All the treatments do that. And that's because if you don't do that, the patients aren't safe and you don't have a treatment, because treatments get destroyed by suicides and by homicides. You may also, if that's not an issue, address other acting out things, such as patients who come late, miss sessions, don't pay, make sexual advances towards their therapists, or use substance abuse, come drunk to a session, or have eating disorders, binge purging in your waiting room, gambling addictions such that they can't afford to come to the sessions. Those are things are also, with all these acting out behaviors, have to be systematically addressed. And all the evidence-based treatments will do that in different ways, but they all are attending to these issues. And one really important one is to address when patients are lying to you, which is difficult. And a lot of times it's not a direct lie. Often, more typically, they're lying by withholding important information. They just don't tell you what you need to know to help them. That's really important to address that if it emerges. And occasionally you have patients who will come and talk about a football game or a basketball game or the weather outside. And we all do that as part of social conversations. But if that becomes the focus of the treatment, then that has to be addressed, because they're using that kind of conversation to avoid meaningful subjects and to avoid emotional topics. And you have to redirect them to the topics that are meaningful and emotional topics. And last but not least, you want to make sure that any patient you're treating is not using the therapy for some secondary gain. So sometimes people will come to therapy to advance their position for a divorce, or come to therapy to get Social Security disability, or come to therapy to get out of work. Those things may come up, and you'd have to address them with patients before you could proceed to a successful treatment. Self-awareness. Now, I don't have to tell this group that self-awareness is critical, and it goes in sort of two ways. You have to be aware of yourself, and you have to be aware of others. And I'm going to make this a little bit more specific. So we know self-awareness is really important, but there are no good ways to measure self-awareness. But there are some aspects of self-awareness that we know a lot about that we can measure and can use those aspects to improve our outcomes with patients. And here are the three aspects of self-awareness that are worth discussing. So in treatments with patients who have personality disorders, it's important to be genuine with them. And what do we mean by genuine? It means that you're your authentic self. You are who you are. It means that you're sincere in what you say. It means you're in touch with your value systems and that those are stable. And that you have your basic intention is to do good work with the patients. And patients have to feel that you are genuinely a sincere person. And this is really important for patients, and it helps them in a couple of ways. One, they see you being genuine, so it's easier for them to be genuine. And that's really important because a lot of patients will put on these personality faces where they look good in one area but act very different in another. And you're trying to help patients be their genuine selves in all settings. So that's really important. And you do that, the way patients pick that up is by modeling with you, but also by creating in your relationship with the patient a genuine dialogue. They have to feel that you care about them. They have to feel that you're honest, that you don't tolerate phoniness, that you don't expect them to be phony, and that you can accept them who they are as a genuine person, even if that's different, even if they beat to a different drummer, so to speak, that you can accept that. A very important aspect of being aware. Now, mindfulness, everyone knows about this at this point. And mindfulness is developing a non-judgmental attention to your senses, to your emotions, your thoughts, more or less a quiet assessment of yourself. And it comes from a Buddhist tradition. Linehan was the first to introduce it, but now it's actually CBT and DBT introduced this. And this is really important. The data on this is really interesting. Teaching patient mindfulness takes them a very long way, but also there's data that therapists who practice mindfulness are also better therapists. So when I get that question, what are the things I can do to be a better therapist? Practicing mindfulness is one of those things. Now, mindfulness is very useful, but there's a thing that comes that's even more complex than mindfulness, which is called mentalization. And mentalization is a much more complex thing. I'll give you an example, a story about mentalization. So I was working with two kids and their mothers from the same school, and one kid was a bully, and the other kid was the kid who was bullied. And I had to talk to both the kids and their parents. So the bully kid was picking on this other kid. And when he got home and told his mother what happened in the school, that he felt that this other boy had made fun of him, and that's why he started to bully him. And that's why he started to bully him. The mother said to him, "You can't be bullied. When someone's making fun of you, you have to stand up for yourself. You have to fight. You have to take care of yourself. You can't let anybody take advantage of you." That's mother one. That's a very non-mentalizing mother's description. The kid on the other side told the story of the fact that he was bullied, and the mom was very sympathetic to the fact that he was hurt, but then asked a very different set of questions. She said, "Why do you think this happened? What do you think your classmate was feeling? What was he feeling? Why do you think he bullied you? What was it that you said that might have hurt him? How did that go?" And you can hear from that description that the difference is that this second mother is looking and laying out for the child that there are multiple reasons people do multiple things. And that a good mentalization means that you explore the fact that our relationships with people are opaque. They're not always very clear. And that there are many, many, many different ways to interpret a behavior, a comment, a thought. And the issue is, if you're a good mentalizer, you can generate those many different possibilities, but then pick the ones that are accurate and use the accurate assessments to decide what to do next. That's a real important capacity for mentalization. And turns out, if you want to develop this, what we call the reflective capacity as a therapist, you can do that in a whole bunch of ways. Take a course on mentalization-based treatment is probably the fast and easiest. But if you do reflective writing, that's another way you can increase your capacity. If you practice mindfulness, that helps with at least half of mentalization, because mindfulness is good for the focused on self, but it doesn't have a methodology to help you think about focusing on the intentions, thoughts, and feelings of others. You can watch videos, you can read, you can do journals, you can get supervision, you can get some consultations. Those are all things you can do if you want to increase your own capacity for mentalization. Now, as I mentioned to you previously, each of the different forms of treatment decides that they want to have a different kind of alliance with the patient. And it's important to know that it's okay to have different kinds of relationships with patients at different times. So as I mentioned, Transference Focused, they see their relationship as the purpose of it is to provide a holding environment and containment of the emotional storms. The fact that you're warm and caring will come from that, but that's not the intention. The MBT therapists, they are much more egalitarian. They don't act as though they're experts. They act like you and the patient are on the same level, that the patient has capacity to know their own mind better than you, and that you have equal capacity to know your own mind, and where you'll struggle is to learn to understand the capacity of each other's minds. But they take a not knowing, non-expert role. And these relationships tend to be more warm. They're trying to facilitate a secure attachment. And they very heavily use the relationship as a motivator for change. Now, the Cbt Group, as I said, they struggle with this the most because of their belief that skills matter more than relationships. But in the MACT version, they are focusing on how to develop a warm alliance, how to deal with counter-therapeutic reactions. And based on that function, they're giving up the collaborative empiricism and moving more towards a coaching role, which is much more similar with DBT. So DBT is kind of the definition of a relationship that's defined as non-judgmental in coaching. And so when you're working with a DBT therapist and something goes awry, they're going to bring you to coach you to use the skills they've taught you, one of the 4 basic skills they've taught you. It is interesting that many patients who do DBT find their therapists are in fact very warm and caring. But that's a byproduct of good coaching. It's not intentional, as the theory takes it, to create change. And schema therapy probably has the most controversial relationship, this idea of a limited parent. We all know that we can act like parents. Good parents is really the idea, right? Give good advice, be kind, be warm. And they believe that that's good with boundaries, so they don't take care of parental functions in a patient's life. They just take on a parental role when they're in session. And they think that that model of being a good parent is a good model for patients to become a good parent to themselves, and a good model to be able to be parental, if need be, towards people who are in your interpersonal world or life. And the good psychiatric management, they take generally a supportive psychotherapy approach. They're supportive, they're validating. It's a supportive psychotherapy approach. Their emphasis, though, is what matters most in our treatment is not your relationship to me. What matters is how you're improving things in your outside world. And so they will emphasize work and going to school and having some successes in the outside world as the major part of what makes patients with personality disorders better. And you can see there are multiple ways to get to Rome. So what all treatments acknowledge is that when you work with a patient who has personality disorders, you're going to have problems. They're going to act out. They're going to get you to act out. You'll say things you wished you didn't say, and that this is ubiquitous. You can't avoid it, even if you've been doing it for many years. So it's important to both know when you're doing something that's not therapeutic, or you have a countertransference that's not helpful, and then you figure out how to manage that. And that's essential when working with the PDs. So there's a continuum of thinking about these problems. So sometimes things in a relationship go wrong because of mistakes we make as therapists, right? So this is the classic countertransference mistake. You have a certain kind of experiences in your early life. I see this sometimes when I work with residents. Residents will tell me they've had a brother who has schizophrenia and that was very frustrating in their life. Then they get with a patient who has schizophrenia and that case goes bad. So that will happen sometimes where you bring something from your own life and it interferes with your seeing a patient clearly. That's the so-called classic countertransference. Sometimes therapists have trouble mentalizing their patients. They can't understand the patient's intentions or what the patient is saying. Again, that can reside in the therapist. And sometimes therapists act out. They do things that are not good for the patient. They shout at the patient. They threaten the patient. They threaten to call the police. These are called therapist treatment interfering behaviors. That can really destroy a treatment with a patient who has personality disorders. So sometimes this happens, hopefully not too much, and hopefully this is the short end of those problems. More typically, the problems happen because of the patient. And the patients then put us in a position where our counter-therapeutic reactions are possible. And the patients do this primarily by introducing behaviors that interfere with their treatment. So they come late, these are the TIBs, they come late, they miss sessions, they don't do the homework, they express sexual interest in you as a therapist, they threaten you if you don't do what they want. Those are all the kinds of behaviors that you might see with personality disorder patients. I had a patient not too long ago who I believed had an antisocial personality disorder. And one of the first things he said to me when he came into session was, "Dr. Feinstein, I noticed you had a BMW out there. That's a nice BMW." And then he went on talking about the BMW. And I'm thinking, why is he talking about my BMW? And is my car going to be there when I get out? Or my tire is going to be slashed? This was a patient who was quite threatening. The other part of this is that most of us are somewhere in between when we have problems with patients. We have something that comes from us that's a little off, and the patient has done something that interferes with our ability to give them care. And you want to be thinking about where you are on this continuum and addressing any of these problems that come up in your treatment. So I want to just say a little bit about countertransference. So some of these therapies don't believe in countertransference at all. So DBT does not, CBT does not believe in transference or countertransference. The others do. So those, the DBT and CBT would rather talk about the problems you have with patients as counter-therapeutic rather than counter-transference. But I think my own bias is that they're missing something when they don't allow counter-transference to be part of their thinking. So I'm just going to mention, which I've already sort of mentioned already, two aspects of counter-transference that are really valuable. So the one is the one I talked about. That's the classic counter-transference, right? And that's where you as a therapist have some unhelpful, usually unconscious reaction to a patient that blocks your ability to see what's going on and blocks your ability to help your patient. And for this, you need consultation. You might need your own therapy. You might need supervision to overcome your classic countertransference. And this is really an impediment to the treatment. But there's another aspect of countertransference that's really important and extremely useful when working with patients who have personality disorders. And this is the idea of a global countertransference, or what others have called a totalistic countertransference. And here's the idea of this. Imagine that we had 25 clinicians in a room and one borderline patient, one borderline patient who has a severe borderline personality disorder. And we asked these 25 therapists to talk to that one patient, one at a time, each for 10 minutes. And then we come back in the room together without the patient and we say to the therapists, how did you feel talking to this patient? And what happens is, of those 25 therapists, they start to say very similar things about the patient. They feel very similarly about the patient. Well, what does that tell us? It tells us that the patient is creating certain feelings in us as therapists that is very useful to know. This is an important form of communication. It's also the same thing that these borderline patients are doing to their spouses and to their bosses and to their friends. It's the same thing that we experience. Now, there's been a lot of interesting studies about using this global countertransference, which is your reaction that you get coming from the patient. How does the patient make you feel that way? Well, we think the mechanism is projection, projective identification, and enactments. That's the method, the unconscious method, the way they transmit these feelings to you. And the implications of that is, if you pay attention to the global countertransference, it really helps you with diagnosis. And there's been, Beitan did a very interesting study of this, where he said that you can use, and this is sort of the way that I work, when I'm trying to figure out a personality diagnosis, I don't go through the DSM. I ask the question, how do I feel with the patient? And I've come to learn that I have certain feelings with certain kinds of patients that are much better indicators of the diagnosis. So I like borderline patients. So when I see a borderline patient, I'm typically excited, raring to go, and feel challenged. On the other hand, when I have a patient who has obsessive compulsive disorder and is now in an obsessional stew, my reaction is boredom. So now those are my personal reactions, but they're also coming from the patients as well. And that's how I start my diagnosis. Then I'll come back the other way and look at the DSM and make sure that my feelings match with the diagnosis that we've talked about. The other part, the other way of dealing with problems with patients is by this concept that comes from CBT and DBT of therapy interfering behaviors. And they have a much broader definition of TIBs, which I think is really useful. And that definition is that any patient behavior, intentional or unintentional, strategic or automatic, calculated or absent, any of those, that adversely affect the therapeutic relationship or the process or the outcome of psychotherapy have to be addressed. And TBIs manifest as resistance to therapy. So some of us will have a patient who has borderline who says, I can't make it to session because I have to pick up my kids. When you're thinking about that in a TBI framework, you would say, you know, is there a reason that you didn't make a plan for this? You know that we meet on Tuesdays and Thursdays at 4 o'clock. Did you make a plan so that your child could be picked up by your husband or by your daughter or by someone else? And if you didn't make a plan, why didn't you make a plan, right? The assumption being that even something as benign as that may be utilized to interfere with the treatment. And if you don't get those things out of the way, then therapy constantly gets interrupted. You don't have the safe space you need to get patients better. Okay, I'll wrap this up right now. So it's also important that you adapt your therapy to your patients. The way to adapt your therapy is by listening to the patient's preferences. Do they want a male or female? Do they need you to have a certain religious orientation? What kind of relationship does the patient need? What are the boundaries they need to set? How firm or how relaxed? How much validation do they need? How much or how little? Setting reasonable expectations for change. There are lots of therapeutic adaptations that we have to make with patients. I'm going to skip this slide in the interest of time. Now, we all know that we will have troubles with patients, and these troubles can, just watching at the time. So we have till 11:30, 12:30, we only have 10 minutes, okay. So we have problems in the working alliance, and I will take them up in this way. When you have a problem in a working alliance, you have to acknowledge the mistakes that you may make, and you have to find a way to get midway between them. So you want to figure out ways to mend the relationship. And part of the way of doing that is to, from the beginning, make sure you have a strong working alliance. When ambivalence emerges in a relationship, consider rolling with the alliance and realize that many times that ambivalence comes because patients want to just maintain the status quo. You may have patients who are acting out very much, and you might have to interpret the deep meaning of why they're angry at you in a transference way. Or you may have to monitor your, change the goals you have for treatment, the tasks you have for treatment, and the bonds you have with patients. At this point, I will stop and leave a little time for questions.
Dr. Feinstein, thank you so much for a brilliant presentation. Your knowledge base is remarkable, and thank you so much for being here. I'm gonna turn to the Q&A and feed some of them your way. And everyone out there, if you have a question, please put that in the Q&A bubble at the bottom, and we will try to get to it as we wrap it up here. I'm going to go from the bottom to the top. There's a very interesting question from Allison McNally here, who says that if she's understanding this correctly, part of what you're telling us is that personality disorders have both a genetic and environmental component, including early childhood trauma. And the question is it important for the patient's therapy to identify the trauma or adverse experiences suffered, or can therapy be successful if the patient can't identify any source of childhood trauma?
I think you have to identify that there has been trauma. You don't have to go through the excruciating detail of what it's been, but you have to, so I have a patient whose parents both died when she was 8. That was very easy to say, but she never thought about it as trauma. I said, you were traumatized, you lost your parents when you were 8. So you have to indicate that trauma is an important part of it. That doesn't mean you have to go through a retelling of the trauma. In fact, there's some evidence that retelling the trauma makes these patients worse. So you have to decide about that. But they need to know that, yeah, it was traumatic that my mother divorced. It was traumatic that my father got sick and was in the hospital when I was between ages 3 and 5. It was traumatic that we had 6 kids and I felt left out and there was no time for me, and therefore I felt invalidated. You have to name the trauma in relation to their experiences. And it's useful to call it trauma or invalidating environments if it's not clearly a traumatic experience. I would say, yeah, that's really important to help them know about that.
Great. Kenneth Burr is writing in asking you if you have any comments on Donald Klein's contribution to the idea of emotional dysregulation as a major component of borderline personality disorder and possibly as a target for psychopharmacologic treatment?
Well, I mean, I would say that DBT thinks that that's the core focus of it, for sure. Don Klein was not the first one to think about that. So yeah, I think it is emotional dysregulation, but if you think about it, it's only a subset of the PDs, right? So it's the borderlines that may have that, and that's really what they're talking about there. It's the borderlines that have that, maybe the narcissistic, maybe the antisocial when they get enraged, paranoid, if you puncture their paranoid, they may have all this emotional dysregulation. But there's another group that has the opposite of that. They're over-controlled emotions, and that requires a different intervention. But in terms of the pharmacology, in my book, which you're welcome to read, there's a fantastic chapter written that reviews all of the literature about the psychopharm. And if there is any psychopharm that helps, it's possibly with the borderlines only, and possibly the mood stabilizers, but a very weak effect and not a primary treatment. So.
Great. I blinked and 5 more questions appeared. So here we go. So, Dr. Gerber out there says, thank you, Rob. I think you offer a remarkably clear and integrative perspective about the treatment of personality disorders. He is wondering if you could comment on why it seems to have been so historically difficult for approaches to be integrative as opposed to heavily identified with one camp or another. And what are your thoughts about how to help the future of our field more embracing of these multiple perspectives?
That's a good one. Well, the trend, as you could see when we went through them, is towards integration. So schema therapy is the most integrated, right? Because they've borrowed from everybody. So I think what we've learned is what's important is that you have a theory. It's less important which one. And it's important that you're systematic in the way in which you approach problems, so that you keep track of what needs to be fixed, what's better and what's not. And it's important that the relationship be there. I have trouble with the way the literature has gone into these psychotherapy wars, where each therapy, and we did that to ourselves. I mean, psychoanalysis sort of said, we're the best, nothing else matters. They had this arrogant attitude, which then made CBT challenge them in the way in which they did. But all of those wars, all they did was make a lot of famous people on a particular line. And if you look at studies, there are very, very few studies that compare one treatment to another. They all compare their treatment to placebo, which just fosters the therapeutic wars. There are just not a lot of people who are integrationists. And I think that's a shame, because the data looks more like we could be teaching common factors and a lot more people would have access, which was my whole talk, that if you know the common features, you don't have to have this specialized training. We can't learn 400 different forms of psychotherapy. It's just not possible. So let's get at the core things that we can utilize to help our patients and share them and stop the battles over it, or at least that's my view. Anyway.
Hey, Rob, many comments appearing thanking you for the presentation, and it will be available on the hospital website. We won't be able to get to all the questions. If somebody wanted to, could they email a question to you? Would that
absolutely
work?
I'm
all
sorry,
right.
I think I
No, that's all right. There's just a few more that are a little bit specific, and we only have a minute left. And I want to end with John Tamron's question from that's really about a patient's perspective here. A really nice question here. If all the treatment outcomes are equal, how should a patient select an optimal therapist? Psychiatrists have websites saying how wonderful they are. How can a patient make an intelligent choice?
So I would say, the best they can do is pick an evidence-based treatment if they have a personality disorder. So any one of the big 6 is okay. And then it's going to wind up being based on access. Which of the evidence-based treatment do they have access for? So, and I think practically that turns out to be DBT is the one that has most access everywhere. That's why so many patients wind up in DBT. But if you want to think about that, it's patients who are very difficult the most difficult patients don't with the exception of DBT, don't typically do well in rigid forms of therapy. So if I have a patient who's very difficult, I might send them to DBT because the skills used in DBT are designed to help them with that. But the other forms of therapy, they don't do well. They do better with transference focused, mentalization-based treatment. The only other thing I would say is that mentalization-based treatment, which is the newest, I'm starting to feel has the best efficacy for most treatments, because mentalization is used by all the treatments in one way or another. And interestingly, that's the only treatment that has really good evidence that they can treat antisocial personality disorders. And prior to that, we were saying that was an untreatable disorder, but their methodologies are really interesting. So I'm leaning in that direction. But any of the evidence-based treatments, they all work about the same. So it's about patient preference and about access. You know, you may not have access to schema therapy in where you live, but you may have access to transference focused. All of them work.
Last question from me. So I'm as we talk about integration, I'm wondering, Rob, is there any evidence that if I'm, say, a mentalization-based therapist and I borrow from DBT and integrate some skills, that actually drops the 70%, that it actually diffuses the peer treatment, or is there something about providing a peer treatment that's important?
We don't know. What we do know is if you just do a hodgepodge of things, it doesn't work. So I think one of the problems with all the therapies is that they're complex therapies. We're doing 20 or 30 different things in each therapy, and we've never deconstructed them to know which part of the therapies are more effective than any other parts of the therapy. So what I would say is stay with one theory, but if you need to borrow something from another theory for a particular patient-oriented way, for a particular patient need, do it, borrow it, because that will give you the adaptation that patient may need to make the therapy work. But try to stay with the evidence. Don't be afraid to do an adaptation, but don't adapt from everything. Adapt focally based on what you think your patient may or may not need.
All right. Thank you, Rob, for your inspiring presentation. And thank you to all of you for joining us today. As a reminder, for those wishing to receive CME and CEC credits, please complete the evaluation survey and feel free to say hi to Rob, who didn't get to see everybody given our format on the evaluation. And that'll automatically pop up in the browser as our webinar ends. I say it every week, but it's a little bit of a harsh ending when we stop here, as we've been together and now we'll be alone in our offices where we find ourselves. So goodbye. Thank you for joining. And this concludes our grand rounds for today. And again, thanks a million, Rob, for being here with us.
Thank you.